So good evening, everybody, and welcome to the presenter series in preparation for the IACT IMDHA HypnoExpo 2022, which is coming your way May 13th through the 15th in Orlando, Florida, with pre and post conference programs before and after that weekend. And in fact, the reason we are here tonight is to talk about those pre and post conference programs. And in just a moment, we're going to be joined by Garry Coles, who will be one of those presenters. So sit back and relax. And I'm going to just turn this over to Karen Hand, who will do the introductions. And
I'm not in this just alone. We're going to be asking questions, but Gary's going to be really running the show. You know what? We understand that it's the middle of the night in the UK,
It
but
is.
I have read that you are called the hypnotherapist, so I know that you can get the right mindset to go for this and
Absolutely.
make it just as if it's the middle of the afternoon, Gary. So, Gary's doing a pre conference. It will be Wednesday and Thursday, May 11th and 12th. Hypno-Oncology, hypnotic interventions for the cancer journey. Amazing, isn't it? Let me tell you a little bit about it. Now, Gary, I'm going to be honest with you. If I read your entire bio, we wouldn't have enough time to hear from you.
Yeah.
So I
Well,
really,
I could go to bed, isn't it?
what we really want to do is hear from you, but let me tell you a little bit about him. Gary is one of the few hypnotherapists contracted to the NHS for hypnotherapeutic work. On the other side of the pond, insurance will pay for what we do in some cases. Gary has over 16 years of hypnotherapy experience in an oncology setting. He's the resident hypnotherapist in a major hospital offering hypnotherapy treatment for myriad cancer related issues. He's received specialist cancer hospital training. He also spent a year embedded in the hospital's breast cancer multidisciplinary team. He attended weekly meetings with the surgeons and oncology team to discuss cases and treatments. I just want you to imagine that for a moment, that there is this hypnotherapist as respected as all the white coat guys in these meetings. How cool is that? And thank you for opening those doors. Gary carried out the first groundbreaking UK clinical research project into the effects of pre-surgical hypnotherapy on the recovery quality of breast cancer biopsies. The results were acclaimed. They're awaiting publication at this point. He has many, many awards. In 2016, the UK Hypnosis Convention claimed Gary to be amongst the top 30 hypnotherapists in the world. Now, those are some pretty big shoes to step into. I'm going to ask you to really impress us, but first of all, I want to know how you got into all of this and all of that, but tell us really first, what is hypno-oncology, Gary?
Hypno-oncology is essentially working with people going through the cancer journey. The one thing that we don't do, which I come from a scientific sort of background and also a very ethical background. So the one thing we don't do, and in the UK, we actually have a 1939 Cancer Act, so that we're very heavily regulated on what we can say, what we can do, how we can interact with cancer patients. So
And does
unless
that
you're
go for doctors too, or that's specifically hypnotherapists? I didn't mean to interrupt, but just for
uh,
clarity.
it's for anybody that isn't a doctor, a surgeon, or an oncologist.
Thank you. Okay.
So unless you're considered to be a medical professional, i.e. doctor, surgeon, and so on, then you're not allowed to work with cancer, treat cancer, or offer advice on cancer treatment. So we're very heavily regulated on that. So the one thing from my ethical point of view is that we do not treat cancer. And now I hear, particularly in the States a lot, unfortunately, but all over the world, I hear a lot of people saying, and hypnotherapists and lots of other complementary therapists saying that we can treat cancer, we can cure cancer, we can do this, we can do that. To my mind, it's not ethical. I have seen, we do know that there are a lot of cases where we get remission for no particular reason. That just happens. But the idea of claiming that it's hypnotherapy or whatever, if that's the case, show me the evidence. Give me the scientific evidence to show that you've done that. That is the big thing. So hypno-oncology to me is we're working through supporting people going through the entire cancer journey from the day of diagnosis right through to cure or sadly, terminal ending of it. That is hypno-oncology.
And so I'm guessing part of the journey is dealing with inevitability if there is not going to be a cure,
Indeed, it is. Yeah, sadly.
and
And,
making a peace with that or whatever it is.
it is, and a big important thing is not only is it making a peace with that for the patient, but a big thing that a lot of people forget is the people that are left behind, the carers, the partners, and everybody else, because that has a huge impact on their lives, not only the patient themselves.
So would you say that you're working with the family as much as you work, I mean, all through the journey,
Yeah.
as much as you are with the patient themselves?
Yes, we are. But from the hypnotherapy point of view, I must admit we tend to work really more with the family towards the end, if that's the case. We tend to work with the patient through the journey because we're dealing with everything through the journey. We're looking at the fallout, if you like, the psychological fallout from the original diagnosis, because obviously that gives fears, panic, what if, they're worried about the operation, what will happen, will I live, and all sorts of other things. So it's the initial fallout psychologically. Then we deal a lot with fears and phobias. People might have fears of going into scanners or having the blood tests or the treatment. We do a lot of work on side effects of treatment. That is a huge thing that hypnotherapy can have an impact on, is the side effects of treatment. We do pre and post surgery work. And then another big area, an experimental area, although I mentioned we don't work with the cancer, we can do experimental work. And one of the areas that I'm very involved in is psychoneuroimmunology, PNI, looking at the impact of the immune system that you can have with talking therapy, such as hypnotherapy. And there's a lot of evidence behind that. Then we look at pain control and other things like that. And then hopefully, all being well, we then look at other things, life factors after cancer, moving forward, how their life might have changed, and so on, and perhaps dealing with other things that they never dealt with previously, going into that side of it. So that would be the patient themselves. With the partners and the carers, it does tend to be generally more towards the end of it, the inevitability and the fears and panics that they have.
Do you run across cases where you have to bring in the family or dissociate from the family because they're giving the patient wrong messages? I mean, we get suggestions all the time. Sometimes the people who give the suggestions are trained and sometimes they're not. And so family members or friends or acquaintances can give some pretty bad suggestions sometimes. Do you deal with that?
We do. I would say the biggest problem with family and friends in the cancer arena is not so much giving bad suggestions, it's not giving any suggestions or any support. The word cancer is very emotive to a lot of people, and it causes fear and panic. And one of the biggest areas that I found in my own research was social interaction was a big issue. And once somebody is diagnosed with cancer, even close family members suddenly clam up. They think, what can I say? They're worried about upsetting them or saying something that's wrong, or not treating them as the same human being. They can't joke with them anymore. They can't have a laugh with them anymore because they're worried about upsetting them. And that is a big thing. They're still the same person. They've just got an illness. They've got a disease. So you still need to interact and treat the person exactly the same as you would previously. And a lot of people can't do that. They just clam up and fall apart. So really, it's not giving them wrong suggestion. It's just actually not interacting with them in the way that they should be.
Gary, I'm still back on something you said a few minutes ago, and it continues to resonate with me. I was surprised to notice my response, and that is that when I hear about cancer, somebody working with cancer, I of course the thing that I think about is about curing cancer. It's where it's where I go first. Similarly, if I hear somebody, and I don't mean to minimize cancer by this, so please don't misunderstand my intention, but if I hear somebody talking about hypnosis in dentistry, The first thing I think about is pain control. Here's some terrible thing, and and hypnosis can swoop in and help that. And yet, I know people that do a lot of work with dentistry, and there's all kinds of things about alleviating people's fears and a whole bunch of stuff. And it isn't just about pain control. In the same way, Gary, just this last week, I went to my doctor. Well, I went to my doctor a couple of weeks ago, who ordered me to go get a scan to check for lung cancer.
Mm-hmm.
And I'll tell you what, so all the technology and all the space age, stuff, and then I go home and I'm sitting here waiting,
Yeah.
waiting, for God's sake, for somebody to, give me a report or let me know everything is fine, or whatever it is. And so there's those kinds of like treatment anxiety and all sorts of stuff.
Absolutely, yeah. I mean, there's a big fear factor there, and the waiting is a big part of the fear factor.
Yeah.
And again, it's just because of that emotive word. It's because the word cancer is used, rather than something else. If you're going to be scanned for sort of a muscle problem, a torn muscle or something like that, you could wait. It's fine. I'll wait and see what happens, and then I'll get treated. Which is the same with cancer, but the emotive wording of it just seems to sort of cause this other real panic in people. And one of the reasons that I even put the sort of the courses together originally was I found that I had a lot of hypnotherapists approaching me that were very highly qualified, very experienced, lots of years of experience and so on. Excellent people, excellent therapists, but they'd suddenly got somebody in their family, whether it was a husband, wife, mother, father, child, or very close friend, and it was suddenly, they've been diagnosed with cancer. What do I do? And it's almost as though their training went out the window. They were suddenly, I'm completely lost. I've got no idea what to do. And so it was really trying to get people back on track to use the skills they've got, to use the approaches that they've got, to move them forward so they can help those people through that journey. That was the original intention. And then I found that something that really makes me feel good is that since I did the training, I'm finding now a very large percentage of people on my training courses are actually doctors and psychologists rather than just hypnotherapists.
How did you happen to get into this in the first place? What directed you here?
It was a complete nutter accident, to be honest. I originally qualified as a hypnotherapist. Out of the blue, well, first of all, when you become a hypnotherapist, the thing that's lacking is experience. That's the big thing you need. Suddenly, out of the blue, I had a phone call a couple of weeks after I first qualified from the hospital saying, somebody's told us you've just qualified as a hypnotherapist. We had one in the cancer unit here. It's very useful with cancer patients. They've left. Would you like to donate some time? And I must admit, my thought at that time was a little bit mercenary. I thought, I need to experience. I'll go there and give up some time. I'll do a few weeks, get lots of experience. And I did have a little bit of a background. I had my grandfather went through the cancer journey. Okay, he lived till his 90s, so that wasn't a major issue. But my mother sadly passed away in her early 50s going through the cancer journey, so I experienced the whole thing with her. So I guess there was some resonation there. But my original intention was to go into the hospital, do a few weeks there, gain some experience, and then disappear. So I did that. I was seeing 8 patients a day, so my experience sort of went through the roof. 16 and a half years later, I'm still there. I didn't get away after all. But that I learned quite a lot. The hospital then sent me on lots of cancer sort of courses, very specialist courses, which was interesting. And then when I decided or had the option to do a master's degree, I decided to make things complicated and do medical research. And that's when I got into the looking at the breast cancer biopsies and pre-surgical hypnosis. And it just sort of went from there, really. One thing followed on from another. And then my idea was I was just giving something back from my skills. I'd done the research, I was giving something back. I'm working with all these cancer patients. I mean, I've worked with several thousand of them. And then this idea, a few people said, you need to put a course together. And I thought, nobody's going to be interested. And then, of course, once I got involved in conferences and I put the course together, and it's just sort of taken a life on of its own, really. And it's now gone the other way round, that it's sort of, if you like, giving me something back from what I gave originally.
Is it kind of the new big thing?
It is at the moment, because the statistics are actually quite frightening. A lot of people don't realize that, actually in the Western world, and we're talking about sort of Europe, the States, Canada, and Australia, 1 in 2 people born since 1960 will actually experience cancer. It's a huge amount. And out of those, 1 in 7 women will get breast cancer, 1 in 8 men will get prostate cancer. Bowel cancer affects 1 in 15 men and 1 in 13 women, sorry, 1 in 18 women. Lung cancer is 1 in 13 men and 1 in 15 women. And SAGE research actually shows that 40% of people diagnosed with cancer will actually seek out complementary therapies. So that's 20% of the population could be looking for you. And the other thing, the thing that's really sort of knocked that to the fore is we've had the COVID pandemic. And I always now say, well, actually, cancer is now the real pandemic, because I know it's the same in the States and over here. But because of COVID, all the diagnosis and all the treatments actually got cancelled, delayed, and whatever. And in lots of parts of the world, there's now a year's delay for diagnosis, for treatment, and so on. Now, cancer needs to be picked up early. But to have the best diagnosis, the best treatment regime, it needs to be picked up early. So if you're suddenly diagnosed a year later, the outcome is nowhere near as good. So that's going to cause a lot of psychological fallout, a lot of panic. So really, I'd have said that now that's the new pandemic. That's where we're needed now to help those people that have been delayed and so on going through the journey.
It is a word, though, that cancer word, that has kind of a bit of an anchor to negativity. Does it not?
Absolutely, yeah, it's very emotive, and it does have that anchor. And it's an interesting thing as well. And not only does that have an anchor, but I touched on the area of psychoneuroimmunology. And the interesting thing there with anchoring is how the fact that anything can be taken on board to us as suggestion. If it's done from somebody in authority, somebody very well respected, it can be taken as suggestion. And to me, it's a big thing that, particularly with cancer patients, you need to pay attention to the diagnosis, not the prognosis, because the diagnosis is facts. It's based on facts, it's based on tests and so on, and you can work with that. The prognosis is an estimate based on statistics and other information. But if you're given a prognosis by somebody in authority, that can start becoming your suggestion and your reality. And that can be a big problematic area as far as anchoring and things is concerned.
I wonder how much of it is involved in the belief system, because a suggestion can create a belief system. You believe that you
Absolutely,
might get over
self-fulfilling
this, you believe.
prophecy.
Right. And there's a woman in our profession now, Bunny Vreeland. I don't know how many people know her, who was given a diagnosis.
She's actually done my course. She did one of my early courses in New
Then you
York.
know very well. Bunny was diagnosed with lung cancer, and very advanced, and she didn't want to do any of the traditional medicine things. Her belief system led her to alternative medicine, immuno. I don't know all the technical terms of it. I've been following her closely. She's such an inspiration. But part of that, I fully believe too, was Bunny's belief system. She didn't have any belief in that medical stuff that was going to make her throw up and all of that stuff. She believed in this, and by God, it's working.
Absolutely, and it can be very, very good for that sort of thing. I mean, but again, this is where we have the problem with the science element. Yes, there's a good example of where it's worked, but how do we prove that that's worked scientifically? This is the problem area,
You have
and
to
we.
have Bunny's belief system, don't you? You have to also have that belief system.
Oh, absolutely. But how do we, the difficult thing is, how do we push that through to the scientific element? Because the problem we have, and one of the things that I want to do is really, really get us taken more seriously by the scientific element, and the medical fraternity. And the only way we can do that is their scientific way. That's why I did the masters, because again, you go into a hospital or something and say, oh, I've got a diploma in hypnotherapy, and it's, oh yeah, great, go away. But a master's degree from a university, that's something they recognize. It's something legitimate, and they recognize, so you're taken more seriously. And once you're taken more seriously, and you get them on side, and then they start seeing results, that's when things start to happen. I mean, in my own research, one of the things that I thought was absolutely fantastic was when I put my research forward, I had lots of problems with ethics committees and all sorts of other things. And eventually I passed all the ethics committees and everything else. And they put me in front of one of the teaching surgeons, and they said, right, this is the final hurdle. You've got to discuss it with this teaching surgeon. If she approves, then you can do your research. If she doesn't, it's not going to happen. And I got the impression that this teaching surgeon, she sat down and it was almost given the impression of, I'm a famous teaching surgeon. Why are you here wasting my time? That was the impression she was giving. And she was asking me really lots of difficult questions. I thought trying to catch me out, but when I look back on it, I think she was just trying to find out that I was serious and I'd done my homework properly and I was credible. That's what she was looking for. And I answered all the questions, did everything else, and at the end of it, she turned around and said, "Okay, yeah, we'll do this. We'll do this research." So I thought that was great. And then what was even better, a few months into the research project, she approached me one morning because they used to have a specific sort of days when they did breast cancer patients. And she approached me one morning and she said, "Oh, I'm seeing some of the results from the people that you're working with." And she said, now we know that the type of patient you need to work with, we know the ones that fit your category." And she turned around and she said, "If you need me to swap my elective list around to accommodate you so that you can get the timings and see as many people as you want to, just let me know and I'll move it around." And I thought that, to me, that was a win situation. You've suddenly got a surgeon who didn't want you to do it initially, now are totally on side that, yeah, I'll actually move my list around to accommodate you because this stuff is happening. And that, I thought, was, to me, that's the sort of thing we want on side. If you can get that sort of reaction, then you're moving forward.
So, how do you prove it scientifically?
Uh, but with my own research, I mean, there is a lot of research out there. In the States, Montgomery's done a lot of research in Sinai in New York, particularly with breast cancer patients. But my own research, and the one that convinced them, was the research I did. We started off with something called an SF36 psychological profiling. It's a gold standard scientific questionnaire, essentially. And the idea of the questionnaire, it's all computerized. There's all sort of clever computer stuff that it goes through. But essentially, you ask people lots of questions, and it gives a psychological profile of whether the person is, if you like, on a very basic level, whether they're depressed or not, and if they're depressed, what level of depression they are, which factors are causing that, and so on, which aspects of the psychological makeup are having problems. So essentially what I did was, on the day of their operation, the breast cancer operation, we did the psychological profiling to see how people were psychologically. We had a hypnotherapy group and we had a control group. Now, once all the data was analysed, it's probably not a major surprise that on their day of their operation, everybody was borderline depressive. I would say that's not a major surprise to anybody. But then what we did is we had one group had the hypnotherapy with me. It was scripted because obviously for scientific research, you can't tailor it to each individual person because we need to get rid of all the differences. So it had to be scripted. We had a group had hypnotherapy just before their pre-meds going into the operation. And then we followed up a week later and we did the same scientific survey, the SF36, analysed the data again. And what was interesting is the control group were exactly the same. They were still borderline depressive, and the same factors psychologically making up that depression were evident. The group that had the hypnotherapy were down to what we call population norm. So if you like, they were back to normal, a normal functioning person without the depression, without the anxiety, and so on. The only element that didn't jump, which was the thing that I touched on earlier, was social functioning. It was social communication was the area that hadn't come back, and that was really for outside forces, family members, friends, and so on. And again, this was all scientifically gold standard sort of questionnaires. So to them, that was proof because it had gone through all the scientific stuff. The other thing we did as an aside, which was interesting, We also did some pain control questionnaires, again, gold standard scientific questionnaires for pain. And what was interesting on that is the control group we looked at the control group compared to the hypnotherapy group, and the hypnotherapy group actually perceived that they were feeling far less pain than the control group a week after the operations. But when we dive down a little bit further, not only were they perceiving less pain, but they were actually taking far less pain medication than the other group. So again, quite some interesting things that we were able to demonstrate and prove.
Harry, I'm wondering, one of my favorite words, by the way, I have to admit, from back in the days when I used to try to cheat at Scrabble, was psychoneuroimmunology.
Yeah.
And it's been a big thing ever since, the time that I first got it. I mean, I've been in hypnosis for 40 years, and I can
Yeah.
remember when that word was first coming around, and now, more and more and more, and we're getting used to it. I guess what I'm curious about when we think about using hypnosis to influence health and health related issues is how is the work that you do with cancer patients different or than any other health related applications? I mean,
In a lot of ways, I would say that it isn't. It's using variations of tools and so on. We're all good at hypnotherapy. Well, hopefully we're all good at hypnotherapy, and we use it for a myriad of issues, a myriad of medical and clinical issues. So I would say that the use of it is no different, depending on what you use it for and how you use it. I mean, obviously, not everybody will use PNI, for example, as a hypnotherapist, unless they're experienced in a particular area. Not everybody will do pain control unless they're experienced in a certain area. Again, as I mentioned, I put the course together because so many very highly qualified and experienced hypnotherapists just didn't know what to do when they're faced in this situation. So I will be totally honest and hold my hand up. I would say there's nothing that I do that a very well qualified, very experienced, very knowledgeable hypnotherapist wouldn't do necessarily. But if you like, the training that I do is like all training is I've packaged that together for you. And if you like, one of the important things is knowing the background as well, because the other very important thing is you need to understand the patient's cancer journey, and you need to understand the lingo, the jargon, or whatever as well. Because if you're in a hospital environment, you're considered to be another professional. The surgeons or the oncologist will send somebody to you. So the patient will come into you, clutching their note saying, "Oh, I've got breast cancer. It's stage 3, grade 2. I'm on Herceptin. I've got this, that, and the other." And if you look at them completely blankly, you've totally lost all rapport, all credibility, and everything else. So you need to have a good understanding on what all that means. And that's the sort of thing I teach as a background anyway, to start with, plus all the techniques. And obviously, having spent that amount of time in a cancer unit, I do know what works, what doesn't work, what approaches work. So yeah, I'll be totally honest, that there's nothing that I'm going to teach that you can't find somewhere else by doing lots and lots of studying on cancer, being very highly qualified, being very experienced and whatever. But it's like all training courses, I'm packaging that for you for this particular thing.
Well, that's lovely. I like your style, by the way. I'm really enjoying listening to you. And for me, that's really such an important thing. When I take a class from somebody, is who they are and how they present what they're doing really matters to me as a learner, because we've all got our own our own ways. So tell me a little bit about your class in terms of how do you do what you do? Is it a lot of hands-on experiential stuff? Is it a lot of data delivery, or how do you do it?
It's actually changing. I mean, I'm doing it slightly differently actually, in Orlando, because the course itself is, and again, everybody learns differently, and everybody likes a different way of doing it. Now, from my own personal style, I like to be taught stuff, and I like people to throw facts at me, information at me, techniques at me, and I like as much information as you can throw at me in the shortest amount of time. and I must admit, I was not a person for role playing and you know, go away and try this technique and be monitored and whatever. As far as I'm concerned, I've got patients that I can practice on, which is an awful thing to say, but yeah, I've got patients I can practice on. I don't want to do it in a classroom. Give me more techniques, give me more facts, give me more information. So that was my preferred way. So my original course was, right, yeah, we're going to have a full day and I'm going to give you so much information, so many techniques, so many scripts, as much as I can throw at you. And then because we introduced the PNI and we introduced working remotely, group sessions and all sorts of other stuff, we found that we've probably got about a day and a half anyway. So I put a lot of stuff actually on a secret Facebook group. So you do the day's training, and then you've got all this other stuff that you can then do afterwards as an add-on. And which I thought, yeah, great, we'll do that. And then a few people said, well, actually, you ought to extend the course to include this stuff rather than let them go away and sort of having to do it themselves. And then I did a couple of courses before COVID lockdown. And one in particular, I was asked to go and teach, it was a private course. I was asked to go and teach purely a group of psychologists in Bahrain. And going out to Bahrain, they said, well, as you're coming out here, we would rather you did a 2-day course because we want to practice the techniques and we want you to monitor us doing the techniques. And that went down very well. So I thought, well, actually, let's modify things. So let's now make a 2-day course where we can have more interaction, we can do practice, we can be monitored, but I can put in all this other half-a-day stuff that wasn't in it previously, and have a nice mix. So perhaps it'll be slightly slower than I'm used to doing, because I just sort of tend to overwhelm people. But we then get a chance to discuss things, plan things, and actually practice things in a monitoring environment.
That's great.
So it's a mixture.
We've mentioned COVID a few times here. You know, I'm so lucky in that I was teaching people how to work online before the curtain came down. You know, and I think I was already about 85% online when COVID came around. I'm really curious as to how this movement towards online therapy has influenced the way that you work with clients, or the way that you teach, or anything, whatever you want to tell us about that. How's that been for you?
Yeah, I mean, it's had some impact. I mean, in the UK, it's more unusual to work with clients online. I think it's because of the distance here, where everything's close together, and also because it's very unregulated here. We have a lot of people that sort of think they want to be a hypnotherapist. They'll do a quick, cheap online course, or a weekend course. I mean, to give a good example, where I live, I can guarantee within a 10-mile radius of where I live, if you really look hard, you'll find between 100 and 120 hypnotherapists.
Wow.
There are and that's within a 10-mile radius. So you don't need to do it online. You can just walk to somebody. And unfortunately, a lot of people are just looking for the nearest and cheapest. So that's a big issue. So in the UK, it is more unusual for people to seek somebody online. Obviously, because of what I do, I'm known a little bit, so I do work with cancer patients all around the world. So I do that online. The teaching's an interesting one. I do prefer live teaching, because you can demo much better. You've got all the hands-on and all the interaction. But one of the things that actually forced me along that line, which has actually turned out to be quite good, was I must admit, I'll hold my hand up. And one of the areas that I'm really bad at is marketing. So that's not my best area, particularly for training. So typically I will do courses at conferences, or I will get somebody else to market them and so on for me, and sort of split the money, do that sort of thing. I had an idea just before COVID that I would market it my first course, because I thought, well, I'll get all the money instead of 50%, so I need half as many people. And the reason for that was I was doing 3 conferences in the UK, and I thought, well, if I can get 3 or 4 people from each course, from each conference, then that's fine. I've still made the same amount of money, and that's great. So I did the first one. I had half a dozen people signed up, and I thought, great, I only need a couple from each of the others. Then COVID hit, the other conferences got cancelled, so I didn't sign anybody else up. Then I couldn't do the course because of COVID anyway, and I approached the people and said, look, do you mind me putting the course off, because I can't do it due to COVID? And they said, well, can't you teach us on Zoom? And I said, well, I could, but I prefer to do it live, but I've got videos of demonstrations and so on, and I can do some demonstrations over Zoom and whatever if you're happy with that. So they came back and said, yeah, go on, we'd rather you did that. Then I decided I'd ask a few favors in and asked a few friends whether I could sort of advertise I was doing this online training on their Facebook groups and so on. And I ended up with quite a big sign up to it, which was great. But then I had a few people that were international and said, "Oh, we're international. Can you do it? Can you record it and we can watch it on backup?" Because because of the time differences, which was great. Which I'm really glad I did, because now when I do sort of podcast interviews, things like this, I always get one or two people saying, "Do you do any online training?" And I said, well, I don't as such, but I do have a Zoom sort of training course that I recorded that you can have access to for, X amount of money. And I think since then, I probably sell 2 or 3 people a month actually pay to watch the recordings. So, so that's been quite an eye opener and very useful.
There's kind of a two-sided edge to that as well, because one of the things that we've noticed is, we're teaching a number of people are certifying hypnotherapists online and teaching a certification course online. And it isn't just about delivering a training to train therapists. It's also, I think there's the issue of therapists learning how to operate online so that they can do that with their clientele, if that's what's appropriate. And there's a whole new wrinkle, has been added into this for all of us to deal with in this changing world. But I'm like you, Gary, by the way. I want to be in the same room with people.
Yeah, I do.
And it's funny. I have been an advocate of online training because I knew it was something that we needed to learn how to do. And I've been a strong advocate of online training. But in my heart, I want to be in the room with somebody.
Yeah, I do absolutely. I mean, I've really missed sort of going to conferences due to the COVID thing, and it's not just for sort of the training and seeing all the other people. But I found I've done a few online conferences sort of during the lockdown, and you just don't get the interaction because a lot of people are watching on catch up, so you're not getting the interaction with people. You're not doing the networking, the chatting in the bar afterwards, and all sorts of other stuff, which I think is a great part of it.
Let me ask a question going back to your research. And you talked about when you were doing the research, you used scripts because it all had to be very orchestrated
Yeah.
and be the very same, et cetera, et cetera. Are there magic words in those scripts? And do you still use the same scripts? And now that you're not in the research element,
No,
do you do it differently?
I tend to adapt to each individual patient when I work, but particularly if we're doing things to do with PNI and stuff like that, because it's a great thing. I'm a great believer, which I teach on the courses, is look at the patient's view of the world, their view of the world, their view of the disease, use their phrasing for everything, feed that back to them, because it's going to be much more powerful than you just going going to a script.
And
Yes,
when
again, I supply lots and lots of scripts for the training, but I'm a great believer that that's just something as a basis, and that's where you work from and adapt, and then work with the client in front of you.
completely agreed. Will you be training how to do that? Because you obviously have the skill, and I'm wondering, is that a skill that can be trained?
Yeah, I find the way that the skill of the training, I think, on that side of things, or the things that a lot of people have remarked on that have attended the courses previously, sort of doctors and things, is actually giving case histories, and particularly case histories of what the case was and how I dealt with it and why I dealt with it that way. And that, I think, is probably the best insight that you can get, because then you can learn to adapt it yourself. This is what I was faced with, this is what I decided to do, and this is why I decided to do it. And thinking outside the box, perhaps. I mean, a good example of that, one that I didn't, and I probably wouldn't do it this way at all now. It was one of my very early cases, but it was the idea of sort of being adaptable on places, and it was one that I had, and it's always something that I joke about in the hospital, is if I get a patient booked into me and I hear the phrase, the counsellors think it would be a good idea, that's normally a case that it's somebody that's had lots of counselling, it's not worked, and they think, oh, well, get them to see the hypnotherapist because we've got no idea what to do. And I had this particular case, and they phoned me up and they said, you're a hypnotherapist, you deal with phobias, don't you? And I thought, finally, they've started to understand what we do. And they said, well, I've got a lady with a severe sleep phobia. Can you deal with that? And I said, yeah, I can deal with that. And the background of it, which I didn't know at the time, was she was an Eastern European lady, very religious. She'd had an operation and she'd reacted to the anesthetic, which had given her hallucinations. And the hallucinations was she saw herself dead in the hospital bed. So she thought that was a premonition and she thought that she was going to die in bed. So that caused a phobia to the extent that she had to be sedated to actually get her in bed, to go to bed at night in the hospital. So it was quite severe. So they said, would I work with this? And so I went down and they brought this lady into me and she's walking around my room. And I'm thinking, what's going on? And they said, oh, her fears got a lot worse. And I said, oh, in what way? And they said, oh, she's frightened to sit down, relax, or close her eyes. And I thought, okay, perhaps you don't quite realise how we work then. So I said, so you can't close your eyes, and you can't. Oh, no, it's too frightening, and so on. And I thought, okay, we need to think outside the box here a little bit. And so I said to the lady, I said, it must be really, really painful for you. And she said, what's that? And I said, well, never blinking. And she said, what do you mean? I said, well, if you can't close your eye, you can never blink. That must be very, very painful. And she said, well, no, I blink okay. And I said, well, how frightening is blinking? And she said, oh, no, I can do that. Okay. And I said, okay. I said, how many times do you blink in a minute? So we started off with that and we timed her. And I said, well, if you blinked an extra time or an extra twice a minute, would that be any more frightening? Oh, no, I can do that. So we started getting a blinking slightly more often. And then we went slightly off. And I said, well, when you do blink, how long do you blink for? And then we said, well, if you blink just a bit longer, would that be frightening? And of course, you can see where we're going with this. Eventually, we built it up that she was blinking for longer, far more often, until we got full eye closure without any fear or panic whatsoever. So it's things like that I like to use in case histories of ways that people might not have thought of working, but you can work with. So it's that type of things that I like to sort of push.
Pretty clever use of fractionation there too.
Yeah, it worked very, very well.
Yeah. And so case histories will be a part of your course.
Loads of them. Yeah, loads of them.
Yeah. And you said you'll offer some of those magic scripts as well.
Yeah, there's about 250 pages of in PDF format of literature. There's I think there's about 30 odd scripts. There's a lot of techniques. I give all the techniques I use. I've actually transcribed those so that you can use them as I do them, plus all the notes and lots of other stuff as well.
So after this course, do you expect students to be able to go out and start working with patients who have that diagnosis?
I do, but one of the things we do is that there is accreditation, and what I did with that, because originally I had lots of people that were very interested, that were perhaps just learning or just interested because they wanted to help. And I've got nobody, I'm not against anybody doing that because I want to get as many people involved as we can. But we had people that were getting involved that I wasn't confident enough that they could then go out and start working with patients. So what I've done is rather than turning them away, we now have an accreditation process. So yes, you can come and do the course, but if you want to be accredited by the Association of Hypno-Oncology Practitioners, you have to pass a written exam, 50 short answer questions, and that tests not only the hypno-oncology side, but also your general hypnotherapy knowledge. So to give me confidence that you know what you're doing and you can go away ethically and work with people. So yes, if you do that, then yes, I'm confident that you can go away and work with people satisfactorily.
And this isn't your first rodeo. I mean, you've trained a number of Americans and people outside the
Yeah,
UK.
quite a few hundred.
Right. And so, do you think Americans, it seems to me, and I could be wrong, Gary, but it seems to me you guys get a little bit more respect in the UK than we do here. Can Americans take this out and have the same kind of success in our systems?
Yeah, I've got again probably a couple of hundred Americans that I've taught, and they're now in hospitals and clinics and doing all sorts of stuff. It does vary though throughout the world. I mean, the UK, you said, yeah, we got respect. We have and we haven't. Again, we don't help ourselves because I think, because it's unregulated, we get hypnotherapists going out and making all sorts of wild claims of what they can do and so on. I mean, a good example, I had nothing to do with the cancer arena, but I had a bit of a disagreement with somebody a few weeks ago. And I had somebody asking for advice on working with borderline personality disorder. There's something I've worked with through a local doctor quite often. I gave some advice. And then somebody else popped up and said, oh, I'm an expert on this. I cure people in one session. And so I went to the person. I said, oh, I'm very interested. I said, first of all, like, as far as I'm concerned, we don't cure anybody. We just assist, facilitate, and so on. But I said, you say you'll cure. I said, what do you do and what's your scientific basis for it? And they turned around and said, well, first of all, they I thought it was quite funny. They said, oh, you're just a hypnotherapist. I'm a curative hypnotherapist, whatever one of those is. And they said, one of the issues we have, they said, borderline personality disorder, they said, is caused by a genetic switch in the wrong place. So what we do is I hypnotize the person, and when they're under hypnosis, I change the genetic switch into the right place, and that cures the problem. And I said, okay, that's good. I said, what's your evidence base for that? And they said, well, at the end of the session, I asked the patient how they're feeling, and they tell me they feel better. And I'm thinking, that's not really going to get us past any scientific and medical fraternities, particularly. So when we sort of come out with that sort of thing, it's not doing us any favors.
Now, the word curative hypnotherapist, however, is quite impressive. I've got to say, I've been thinking about running a seminar on how to enhance your life with the cunning use of adjectives. This would really do it. So this is a 2-day course at the conference. Is it the same thing that you would do if it was a non-conference thing, or do you have a longer course, or how does that work?
No, that is the longest it's gone. It's moved from 1 to 2 days. It is designed for qualified hypnotherapists. So, I don't teach you things on, I don't teach you inductions, deepeners, how to bring somebody out, and all that type of thing. I'm assuming you're going to know that. You're going to know basic things like submodality techniques and so on. We'll get you up to speed if you don't, but, I'm hoping that you know all that sort of stuff. So we're teaching you purely sort of to come in from the cancer side and work with people from there. So it's building on the skills that you already have. But one of the things that also is included in it is that we have a private Facebook group, and anybody that's done any of the training can then becomes part of the Facebook group. And going forward, any research that I find, I put up in the Facebook group. If I happen to write another script for somebody for something particular, that goes up on the Facebook group. And if anybody wants to ask any questions or needs any sort of mentoring on anything, that's all done through the Facebook group. So it's not a case of, well, you do the course and then we leave you. I'm always there. So for people that want advice or assistance or support.
That's good. By the way, Garry also has one other 1-hour presentation on Friday, Cancer, the New Pandemic, which we touched on a little bit here today. So you won't want to miss that either.
Yeah, that's essentially that's the sort of the 2-day course distilled into an hour. It's a flavor.
Well, I like facts and information thrown at me, so that hour might be perfect for me. If you try to consolidate all of this into that hour, I'll be ready.
Fantastic.
Just soak it up.
Well, I'm just noticing we're less than 5 minutes away from our ending point already.
Yes, time goes fast.
So fast.
Yeah, I got to be up in 5 hours for clinic.
But so I wonder, before we end, just to make sure people get a chance, if there's anybody out there that has any unasked questions, why don't you just go ahead and tap your microphone open and let us know what you need to know before we wrap this up. Anybody at all?
Patty, go ahead.
Yeah, you mentioned accreditation through this is your organization, right?
It is,
the oncology. I'm very interested in that. Now, if they take the 2-day training, is that, I'm just trying to recap what I heard. I was writing furiously here, but do they need more training in order to get accredited through your group and join that Facebook page and all that?
No, you get to join the Facebook page just because you've done the training. So that
From the
you get
2-day
that
training.
way. Yep. The accreditation, you have to do a short answer 50-question exam. There is no further training you need to do, but some of the questions are really geared up to understand your knowledge of hypnotherapy. So it's not stuff that there's a lot of it that I train on the course, so we test you on that. But we test you on your basic knowledge as well to make sure, in my mind, that you've got the competency and the ethics to actually move forward in doing what I think you should be doing.
Beautiful, because I have some students I know would be interested, including myself, by the way. So the accreditation would be through your group, and you would get what, a certificate and just the ability to say that you have taken that training.
Yeah, well, you get a CPD certificate to say you've done the training, and then you get an exam pass accreditation certificate if you do the pass the exam. Because some people don't want to do the exam, they just want the knowledge and they go away and do it. But some people would prefer the accreditation. So you get the choice, and there's no extra charge for the accreditation doing the exam or anything like that. No extra courses, no extra charges. It's all included.
So forgive me for taking a little bit of time, but since my classes are the same days as yours, unfortunately, I can't take yours. So is this offered online? Is this offered separate from the conference?
There is an online
version. Refer people to?
There's a one day online, because obviously you're not doing all the practice with me monitoring. So there is a 1-day version that's available online, which with the extra stuff in the groups it's about a day and a half now. But yes, there is an option to do it online.
Thank you.
But again, we want to see Garry in person and do some of the monitored training and that kind of thing. It is a pre-conference on Wednesday and Thursday.
11th and 12th of May.
Yes, 11th and 12th of May. Hypno-Oncology, Hypnotic Interventions for the Cancer Journey. Garry Coles. If anyone has any questions before then, how do they get in touch with you, Garry?
The easiest thing is to go to the website, which I shall duck down so you can see it. There's a website, hypno-oncology.com. For people that want to sign up to the course and so on, and the conference, there is a special page as well, which is hypno-oncology.com/IMDHA 2022. And that gives an overview of everything that's on the course, and then whizzes them through straight to the sign up for the conference and the course.
Thank you so much for taking a bite out of the middle of your night.
You're right. And also on that side, if you go to that website as well, there is a sort of a page where you can contact me as well. So if anybody has any further questions or wants to chat to me on whatever, just fill in the form and I will get back to you.
Great.
And I'll bet, Garry, that you don't have to blink your eyes too many times in order to rest this evening. So thanks so much for joining us and for sharing this with us. And ladies and gentlemen, Garry Coles, we'll look forward to seeing you in Orlando.
Yes, thank you very much. I'm looking forward to it. Looking forward to it. It's a nice sunny weather.
All right. So thank you, everyone. You might look tomorrow if you're interested in seeing some of this again. This video will be posted in the Facebook group, the virtual chapter Facebook group. Actually, it will be posted in the virtual chapter. What do you call it? YouTube channel. It takes me a minute here, and it will also be posted in the IACT IMDHA Mind Matters forum, which is available to members at either of the association's websites. So thanks again, Garry. Thanks everybody for being here. And
thank you very much, and look forward to seeing you in Orlando. And good night from the UK.
Good night.
Night all.